Okay, we're going to go from too low pressure to wanting to lower the pressure further. And Dr. Pro is going to talk about some of the work he's done with anti-VEGF and filtering surgery. Michael.
Thanks, Jay. Sort of moving on, I think this discussion, we've sort of hammered a little bit on trabeculectomy and complications. I mean, that's not to say that it's not still an effective procedure, and my personal belief, it's going to remain so. It's going to remain something that we need in our armamentarium against glaucoma for years. But anyway, to briefly show you some slides of things you've all seen: hypotony, bleb leaks, blebitis, and endophthalmitis. So many of these complications are thought to be due to the antimetabolite mitomycin C, or you could even substitute 5-FU. So I would say, just my own experience and looking at the literature, about every 10 years or so, at least, there seems to come a new agent along that people think may be safer as an adjunctive therapy. And, there is some interest right now in anti-VEGF therapy, which has shown so much benefit, obviously, in retinal disease, where it's really come to really change the whole paradigm of care of macular degeneration and diabetic retinopathy in some degrees. Anyway, the anti-VEGF agents, inhibition of vascular endothelial growth factor has been shown to reduce scar formation and neovascularization, prevents fibroblast proliferation theoretically. And so in terms of glaucoma, there are case reports in series demonstrating the use and possible benefit of anti-VEGF agents in glaucoma surgery. But none of these series are very large, and each has a slightly different design. So there's been some interest here at Wills to see what we could find. And so I'm going to briefly go through two studies that we've done here that are right now in review. And, certainly open it up to the floor if you have any experience yourself with using anti-VEGF. So the first was needle bleb revision with bevacizumab. Avastin is obviously easier to say, and mitomycin C compared to mitomycin C alone for failing filtering bleb. So this was a needling, kind of paper. These are patients that already had a trabeculectomy or had an express shunt, and these were patients that were then going to be needled. And you would randomize these patients to being needled with the mitomycin C alone for the control group, or being needled with mitomycin C plus an injection of subconjunctival Avastin. The control group then would also receive an injection, a subconjunctival injection, but it was just BSS, and it was a prospective 6-month follow-up. Success in this small series was defined as a 20% reduction of the IOP. Qualified success defined as a 20% reduction of IOP with IOP-lowering medicines, and then failure being defined broadly as IOP greater than 21 or IOP reduction less than 20%, or the need for further surgery. And the bleb morphology was classified using the Indiana bleb grading scale, the IBAG scale, which has shown some utility in quantifying bleb design and some benefit in perhaps predictive function of those blebs. The IBAG scale, in brief, talks about the extent of the bleb, the height of the bleb, the vascularity of the bleb, and whether or not the bleb is Seidel positive or negative. So basically, in this paper here, we have patients 29 in the Avastin group and 29 in the control group, and you can see that complete success is achieved in about 57% of the Avastin group, 41% of the sort of BSS group. And so this is a needling, again, this is a needling study. Remember, this is not primary trabeculectomy. I think this is consistent with other papers that have shown that, bleb needling is not necessarily 80% effective or something that we sometimes will quote our patients. And I think it's fair sometimes when you're doing a needling to tell your patients that, there's about a 50-50 chance. I think other studies have shown that, plus or minus. Qualified success is then adds a little bit to the BSS group. They have a little more, some qualified success. And failure, again, the inverse, failure almost in 50%. So really no difference between the groups, although you might think that the Avastin group at 6 months has perhaps, a trend towards greater success. But again, nothing statistically significant there. The IOP lowering medicines, once again, no difference at 6 months. However, it looks like there's maybe a trend towards less medicines in the Avastin group than in the BSS group alone. And remember, just to keep this in mind here, this was one injection of the Avastin. This was not sort of serial injections like you might do in retinal disease. And the intraocular pressure response sort of being shown here that of those patients that were followed out to 6 months, the pressure average was about the same. So in brief, we found a significant difference, though. There was one result here that may or may not prove beneficial in a larger series. We found a significant difference in the bleb morphology in the Avastin MMC group versus the mitomycin C group. In particular, there appeared to be less vascularity in the Avastin group. That sort of goes along with the mechanism of action you would expect with the anti-VEGF agents. I mean, there's decreased vascularity, perhaps decreased fibroblast proliferation, you might think, but that didn't show up in overall better IOP control or success. Again, no success in either group. What are the results there, as I mentioned? And, from this paper, you might wonder, would Avastin be useful in sort of that subset of patients who tend to have more postoperative vascularity, and who are those patients? I mean, I would almost open that up to the audience. I think we've all had some patients in whom we do a trabeculectomy, and then they basically have a fairly stable course, and they have this white, quiet conge afterwards, and they tend to do better. And then you have that other patient in whom, even though you're giving the exact same postoperative regimen, they're each getting their prednisolone acetate at whatever regimen you normally do it, so our conge is just red and angry, and they don't tend to do as well, at least in my experience. And so you wonder, would Avastin have been useful in that group? Would it have maybe decreased that vascularity and perhaps increase your success with that subset? This paper didn't answer that, but a larger series may help better define the role of anti-VEGF agents in bleb needling. So that was this paper. And before I go on to the next lecture that I have, any experience amongst the group with bleb needling using the anti-VEGF agents like Avastin?
I don't have any experience, but what do you think about the use of the Avastin in intracameral? You thought the work of the doctor, I don't remember the lady doctor from Netherlands.
The what?
She's talking about that like 4 years ago.
I think that was in neovascular glaucoma patients. Okay. I know that there's some intravitreal and intracameral studies with neovascular, which has obviously shown some benefit. I'm not as familiar with that other paper. I'll have to look it up. And again, I don't know if that answers the question because I didn't run into it as much. If we can find that reference, I'll look it up. Again, I don't know the answer yet, and this is trying to answer that. So you could either give it subconjunctivally, like we did in this paper, or you could give it intracamerally, or even intravitreally. And I think certainly right now, none of the studies have really defined the best location to put it. Some theory is that if you put it intravitreally, it maybe has a longer duration of action if there is vitreous present, because it will then slowly diffuse. So that's a theory.
Our experience was not using concomitantly both medications, but using the anti-VEGF afterwards, after the intraoperative use of antimetabolites. And I think we have not particularly rated the results, except for a poster we presented in our studies some time ago. The vascularity was significantly reduced with the anti-VEGF using after in the operation, but the antimetabolites inside the operation. And I think I remember a paper of Augusto Paraños that concluded that using both of them intraoperative at the same time, the efficacy counteracted each other.
I think there's an idea. That's a good point. So in other words, you were adding your anti-VEGF agent sort of after the fact, in the office? Was that in an office setting afterwards, or?
An office setting, yes.
Mm-hmm. Okay. I think there's an idea here, and you quoted that one study that perhaps there's a greater antigen load if you put both the Avastin or what have you and the antimetabolite in the same time, and you might actually therefore not be doing the beneficial effect you had expected. So that's, again, unanswered, but one of the theories I've seen.
We presented last year this paper that we use in rabbits, the bevacizumab together with the mitomycin C, and tried to find out after 1 month the anti-VEGF, the presence of anti-VEGF after 1 month of the surgery, and we did not find almost anything. It suggests that if you use both, mitomycin could act like, well, we cannot see the vaccine after that. I don't know if we do that before or after. Maybe we can find something, but when we mix the two things, it could be like no response at all.
Right, and it could just be that the subconjunctival duration of action of Avastin or Lucentis, which is what I'm going to look at next, is just not great enough, as there's still sort of a fibrotic response that's long-lasting after an injury such as a trabeculectomy. So the second study, which is again this is more of a pilot series, a pilot study. This was ranibizumab, Lucentis, versus mitomycin C in primary trabeculectomy. These are patients that had never had glaucoma surgery before. And this was, again, a prospective pilot study. This was 12 study patients and 12 controls. The study patients received the standard dose of Lucentis in a superior subconjunctival injection to terminate the case, and they did not receive mitomycin C. The 12 controls had mitomycin C, which was applied with a standard application of sponges, soaked sponges, and that was applied for 1.5 minutes prior to the creation of the scleral flap. The groups were compared for up to 1 year with your standard comparison, IOP, visual acuity. Eye bags was also graded, and they had a subjective, discomfort scale that they reported on. And just to sort of skip to the results, reduction in IOP from baseline was significant in the mitomycin C arm, but not in the Lucentis arm. There was a significant reduction in medication use in the mitomycin C arm at 6 months. The eye bags was notable for slightly less vascular blebs, but only really in day 1 for the Lucentis arm, and really not after that. Was notable for less extent at month 6, which might have just been a reflection that in this study, this small study, the Lucentis arm alone tend to have more failures, so your blebs are going to be less extensive. There was more early hypotony in the Lucentis group, but no long-term adverse effects in either group. And we felt that the early hypotony may have been due to surgeon technique. Perhaps surgeons not feeling, again, they're not blinded to the medicine that they're giving. Surgeons not feeling as confident that the ranibizumab is going to give the same reduction of long-term pressure, maybe going a little more aggressively in terms of how much they're letting the flap flow early on. 4 patients in the ranibizumab group had failure of IOP control and wound on with having tube shunts. So in brief, in this small series, a single dose of Lucentis at the time of trabeculectomy was inferior to mitomycin C applied during surgery. And perhaps the theory is maybe repeated applications may prolong the antifibrotic effect, but this study was not designed to answer that question. So that's any experience with that, with anybody using either Avastin or even Lucentis in place of an antimetabolite in trabeculectomy. So there are other things. I mean, this is not the only one. In fact, there's other materials that people are looking into. Olagen, another material. There's an idea that you can use a different sort of a synthetic collagen matrix. So I think the search will continue for things that may prevent some of the complications of mitomycin C, but we haven't hit onto the perfect material yet. Thank you.